Thank you, Kathy, and thank you for the invitation to come and talk to you. Can you hear me at the back there? It's always difficult following Gareth, and you need to readjust your ears. So I'm going to talk to you about antibody therapies, and that's mainly in HER2-positive breast cancer. I think we all know that trastuzumab has been established for many years and has made a very big difference to how we treat HER2-positive breast cancer and made a big difference to the outcome for patients with HER2-positive breast cancer. I'm also going to talk a bit about, well, I'm not going to talk about BRCA testing itself, but I'm going to talk about how we sometimes use or think about treatment options, particularly drug therapy options around BRCA testing. So that's largely about how we perhaps moved a lot of our population from adjuvant to neoadjuvant treatments for both HER2-positive and triple-negative breast cancer. And we've done a lot of that in Manchester over the last 2 years. And I'm going to talk a bit about what's coming in the future. So that's antibody therapies for triple-negative breast cancer. So I think you're all very familiar with trastuzumab, and please interrupt me if you want any clarification. But the trastuzumab trials were done in the early noughties when I just qualified as a consultant, and I was involved in these studies, and it was a great time to be practicing medical oncology in breast cancer, because things really changed for what we thought was the worst type of breast cancer to have to what we now actually think is sometimes the best breast cancer to have. At least we've got really good treatments and we can actually make a big difference in terms of outcomes. So there were over 12,000 women entered into 4 big studies around the world. 2 of those were in North America, 9831 and B31. And then the HERA trial, which was it was outside of America, around the world, the main trial done in Europe, and BCIG 006, which was a crossover between North America and the rest of the world. And they looked at various different treatment strategies, but basically it was chemotherapy with the addition of trastuzumab. In those days, we used to use HER2 to determine whether giving chemotherapy was useful, because HER2 was a risk factor, we knew, and therefore we built that into our models to think, well, if you're HER2 positive with other factors being equal, you have a 1.5 times risk of getting metastatic disease in the future, and you need to factor that into giving chemotherapy. And then we were able to add on trastuzumab. Obviously, things have changed very much since then. Now we test everyone with breast cancer for HER2 status, and that's really changed the population completely. And I might just touch on that in the future. If I don't, then you might want to ask me. So the duration of trastuzumab was unknown, and it was pretty much plucked out the air as 1 year for most of the trials. In the HERA trial, 1 year versus 2 year was a comparison. That's a randomized comparison. And probably because the median time to progression on first-line treatment in the metastatic setting was a year if you had trastuzumab in the mix. I can't think of any other reason. It was otherwise pretty much random. But we know that these trials all read out and showed a big difference in terms of all their outcomes. So HERA showed that there was an improvement in, on the left we have disease-free survival, and on the right the hazard ratios for overall survival for all of these trials. And HERA, the initial readout was a hazard ratio of 0.54 for disease-free survival. And then that moved across a bit because half the population switched over to trastuzumab once the trial results were known. But it remained stable at around 0.76 subsequently. And the other trials similarly have shown some variation as to whether or not you had crossover or you stayed on the allotted treatment, which was basically the BCIG 006, which didn't allow any crossover. So the more mature data from the HERA trial, which also looked at 2 years versus 1 year of trastuzumab, shows firstly that there's no difference between 2 years and 1 year, and also that over a period of time the results from the initial presentations are solid, but also that there's still a significant proportion of patients who are relapsing with HER2-positive breast cancer in spite of trastuzumab. So there is a need to think about new therapies. And at the same time as the 4 big trials presented their data, there was also this very small trial from Finland, which I think most of you probably have heard of, the FinHER trial. All the other trials had some relationship with Roche, either as a provider of the drug or a co-sponsor or a third party, but interested in what was going on. And of course, HERA, which was an academic study, academically led study, was the registration trial in the rest of the world, or became the registration trial in the rest of the world. But the FINHER trial just looked at 9 weeks of trastuzumab. So that was in combination with docetaxel or vinorelbine chemotherapy at the outset, and then the patients received their anthracycline chemotherapy subsequently. But the hazard ratio in this trial was similar to those in the larger trials, that the hazard ratio for disease-free survival at initial presentation of the data was 0.54, and with longer follow-up that's actually improved to 0.32, and the hazard ratio for overall survival is 0.42. So these data are holding up over a long period of time, and I think it sort of reflects some of the things we have learnt during the time we've been using trastuzumab, that giving it upfront with chemotherapy is probably the best thing to do, and that makes the biggest difference. We also learned from this American trial, 9831, which had, as well as a randomization between trastuzumab and no trastuzumab, a randomization to receive trastuzumab in combination with a taxane portion of chemotherapy or sequentially after the taxane was delivered. And that was the mode of delivery in the HERA trial. Everyone received their trastuzumab after completing their chemotherapy, and also after the radiotherapy if that was part of the treatment package. And from the concurrent versus sequential trastuzumab treatment in the 9831 trial, there was a 5% improvement in the disease-free survival, a hazard ratio of 0.77. So just giving the chemotherapy with the giving the trastuzumab with the chemotherapy actually has a difference in terms of effectiveness. And we know that because when we give it in with chemotherapy in the metastatic setting or with treatment before surgery, we see higher response rates, and that sort of all fits together, as well as the original data looking at mixing trastuzumab with chemotherapy in the lab and looking at additive or synergistic effects. So what's changed since then, and why have we become so interested in primary medical therapy, neoadjuvant treatment? So the interest, I think, largely arises from this meta-analysis performed under the auspices of the FDA, the Food and Drugs Administration in America, led by Patricia Cortazar, who did work for the FDA then. She now works for Roche. I don't know why that is, but there you go. Anyway, they looked at whether you achieve a pathological complete response, and we need to be clear about what we define as pathological complete response. So they used a definition of absence of invasive cancer in the breast and absence of invasive cancer in the lymph nodes at the time of surgery. And looking at both breast and lymph node eradication is clearly better than just looking at the breast alone. So when you look at the eradication of cancer in the breast and the lymph nodes at the time of surgery, in the population as a whole, and how does that correlate with the outcome in terms of overall survival or disease-free survival or event-free survival. So in terms of, if you look at all the patients treated with neoadjuvant treatment, if you achieve a pathological complete response by that definition, your odds ratio for an event-free survival event is 0.44, and for an overall survival event is 0.36. But in the HER2 positive population, where trastuzumab is included in the treatment, that's just one trial, a very small trial, the NOAA trial. The hazard ratio for event-free survival was 0.15, and for overall survival 0.08. So suggesting that giving trastuzumab and achieving a pathological complete response correlates very well with a event-free or overall survival outcome. So these are the curves for a pathological complete response and event-free survival in the HER2 positive population. On the left, all the HER2 positive population. In the middle, the hormone receptor positive HER2 positive patients. And on the right, the HER2 positive hormone receptor negative. We know that patients who have HER2 positive and hormone receptor negative cancers, their cancer is more likely to be driven by the HER2 expression, whereas if there's estrogen receptor expression as well, that might be the driver of the cancer, or there might be a switch between one and the other, or they may talk to each other. So the achievement of pathological complete response for the overall population resulted in an event-free survival hazard ratio of 0.39, for the hormone receptor positive, HER2 positive 0.58, and the hormone receptor negative HER2 positive 0.25, and that's not just the ones with trastuzumab in the treatment. So a lot of these patients, or a lot of these trials were from days gone by where selection of patients wasn't by the biological status of the cancer. It was all larger breast cancers that you might think about giving neoadjuvant treatment to because you want to shrink it before you do the surgery. And some of that still remains relevant, but I think some of us have changed the way we're thinking about delivering treatments. So if there was a perfect correlation between the event-free survival hazard ratio on the y-axis and the pathological complete response, the curves would look like this. But they don't look like that for all the trials, so there's no real relationship in the trials as a whole. But again, this is a mixed population in most of these trials, no selection about the HER2 status or the ER status, and not selecting by treatment related to which type of breast cancer you've got. And the only trial that seemed potentially to lie on that perfect fit curve was the NOAA trial, but again, it's a very small trial, but there does seem to be a strong correlation between outcomes. We know that the addition of trastuzumab, Herceptin, the H in this histogram, significantly improves the pathological complete response to 38% compared to 19% in the HER2 positive population just treated with chemotherapy alone. This trial did also include a HER2 negative population, but that's not really relevant for this discussion. And in the trial as a whole, the addition of trastuzumab did improve the outcomes for the whole population. This isn't looking at the per patient PCR rate though, so the data for that were not available in the publication. So where we've gone from there, we've gone to adding another antibody which is routinely used in the metastatic setting. This is pertuzumab, and it works in combination with trastuzumab. Originally, Roche wanted to explore this drug in a HER2 negative population where it has no effect whatsoever. But fortunately, before binning it, they did some animal studies in HER2 positive xenografts in mice, and they showed that there was an additive effect in combination with trastuzumab, and then that went into a program of development. So HER2, as you know, is a transmembrane protein. It needs to dimerize to activate its internal tyrosine kinase portion, and that sends signals inside the cell to activate the cell. HER2 can combine with other partners, HER1 and HER3, and it's thought that HER2, HER3 dimers are particularly bad at driving cancer growth. Pertuzumab stops that dimerization. It stops dimerization of HER2 with HER2, HER2 with HER1, HER2 with HER3. So it acts as a blocker basically between those two proteins coming together and starting an intracellular signaling cascade. Trastuzumab binds to a slightly different portion of the extracellular domain of HER2. They both have a humanized tail, which is an IgG gamma antibody, so it has the potential to interact with the immune system. So that is probably part of its activity. We still fully don't understand how the combination of the drugs or the drugs on their own work, but they certainly work better together. And after a series of phase 1 and phase 2 trials, a phase 3 trial of patients in the first-line setting with metastatic breast cancer treated with pertuzumab in combination with trastuzumab and docetaxel versus placebo, trastuzumab and docetaxel showed a very significant improvement in overall survival. So this is the biggest difference we've ever seen in overall survival with drug therapies in metastatic breast cancer, an improvement of 15.7 months. So patients now with HER2 positive metastatic breast cancer are living a median of 5 years. Some of them are going out for a lot longer than that. Obviously, by definition, half the population. And the hazard ratio for the improvement is 0.68. So just taking that treatment now, the combination of two antibodies with chemotherapy or without chemotherapy in the case of the Neosphere, and giving it to patients before surgery, you can improve the total pathological complete response with docetaxel and trastuzumab from 21% to 39.3%, and this is just 4 cycles of the combination of docetaxel, trastuzumab and pertuzumab. 2 other studies, two other treatment arms in that trial which are not currently licensed, but one of great interest is the combination of the two antibodies together, where you do get a pathological complete response rate of 11%, and whether that might be an option for the future needs further exploration. But another trial looking at various different combinations of pertuzumab, trastuzumab with different chemotherapy schedules. So one of those was the carboplatin docetaxel trastuzumab combination from the BCIG-006 trial, and adding pertuzumab to that. That's TCHP on the right-hand side. Also looking at a full 6 cycles of pertuzumab in combination with the anthracycline portion of chemotherapy. Now, we wouldn't normally give HER2-directed therapies in combination with the anthracycline because of the increased risk of cardiac toxicity. And this was mainly a cardiac study looking at the safety, and the short-term safety was not an issue. There were very high pathological complete response rates in all the arms with a combination of either 3 cycles of pertuzumab with trastuzumab or a full 6 cycles. And so in the UK, we now have access to either 4 cycles or 6 cycles of the combination of pertuzumab with trastuzumab preoperatively in patients who have a HER2-positive breast cancer that's more than 2 centimetres or lymph node positive. And that's NICE approved. And I think a lot of us have changed the way we treat these cancers because of that, and that the access to the extra treatment and the potential that pathological complete response might be an important determinant of longer-term outcomes. The reason that pertuzumab was approved by the FDA on the back of that Cortisar meta-analysis, but was also on the basis that this trial, the Affinity trial, had completed recruitment, so 4,800 patients with HER2-positive breast cancer post-surgically randomized between chemotherapy, trastuzumab and pertuzumab, or chemotherapy, trastuzumab and placebo, and this was the full duration of 1 year of treatment. Primary endpoint was invasive disease-free survival, with secondary endpoints of invasive disease-free survival, including second non-breast cancer primaries, disease-free survival, overall survival, relapse-free interval, distant relapse-free interval, and safety outcomes, as well as quality of life. So some stratification factors were whether or not you had anthracycline chemotherapy, hormone receptor status, node status, geographical reason, and protocol version, because there was a protocol amendment during this treatment. It did allow patients in who had node-negative cancers, as did the original trastuzumab trials. In the original trastuzumab trials, you needed a cancer that was at least 1 centimetre in size if it was node-negative, and this trial allowed cancers that were greater than 5 millimetres with various other risk factors if they were node negative. But a very small proportion were in that category, but about a third of the population were node negative, and the amendment was to maintain that difference of 1/3 to 2/3 node negative to node positive. So there's not a lot of difference, but it is statistically significant. So a hazard ratio of 0.81, which just crossed the statistical boundary of being positive. The confidence interval is slightly less than 1 if you look at all the notes, but it's rounded up to 1. But there's not a huge lot of difference there, and one might question whether this would be something we could afford in the NHS, and certainly that's the initial view of NICE, that it's not cost effective, and it's in the middle of its NICE appraisal at the moment. The median follow-up of the trial at this time was 45.4 months, so as time goes by we might see some difference, but I think one thing it does show is that we've got a lot better at treating HER2-positive breast cancer than we were at treating it in the early 2000s. In terms of what is perhaps the driver of the difference, if any, it's probably in the node-positive patients, which we know is still the most important individual risk factor in terms of prognosis for patients with breast cancer, and also the hormone receptor negative subgroup, which are both more biologically aggressive and more likely to have their events earlier, but also potentially more susceptible to treatment with dual antibody therapy. But we have changed a lot. So as I said earlier, we've got a whole group of people who we'd never think about giving chemotherapy and trastuzumab to, certainly not giving chemotherapy to in the days before trastuzumab was available in the adjuvant setting, but we're testing everyone for HER2 status. So you sit in the back of the MDT when you're a medical oncologist, you're half asleep because there's a lady and her late 60s, early 70s, but she's fit. She's got a screen-detected hormone receptor positive breast cancer. It's relatively small, but it's HER2 positive, and you have to start having that conversation about. Firstly, we don't have a lot of data to really know what happens with these cancers if you don't treat them, but there are a number of case series that suggest the outcomes are not good, whereas other case series suggest that they might be better than the case series that suggest they're not good. And how are you going to treat a patient? You know, are you going to give them the full-blown anthracycline-based chemotherapy with a taxane and trastuzumab, or is there an alternative? And I think a lot of us have started using this APT schedule that was looked at in a phase 2 study, single center study, first presented in 2013 by Delaney, and it's weekly paclitaxel for 12 weeks in combination with weekly trastuzumab for them, but then switching to the 3-weekly schedule of trastuzumab to complete the year of treatment. And that's certainly a much easier tolerated regimen than some of the other ones that we use. And in terms of the outcomes from disease-free survival, recurrence-free interval, disease-free survival according to tumour size, whether it's more than 1 centimetre or less than 1 centimetre, and the disease-free survival according to hormone receptor status, they all seem to do quite well. But this population is a population of patients with smaller cancers. The vast majority were node negative, and a large proportion of them were T1 cancers with very few T2 cancers. So it's perhaps a treatment that we'd select for patients of lower risk or have other personal characteristics that make them less suitable for more aggressive chemotherapy regimens. What other strategies are there for de-escalation? So based on the FINHER study, we started a trial led by Helena Earle many years ago. In 2007, this trial actually started, of 6 months versus 12 months of trastuzumab for patients who'd had standard chemotherapy. And that was because the licensing trials were pretty much empirical. The FINHER data seemed to suggest that there was a rationale for giving a shorter duration. And the HER trial also, as this trial was going through its recruitment, showed that 2 years was no better than 1 year. So it's 4,000 patients with a 4-year estimated disease-free event rate of 80%. And we wanted, it's a non-inferiority trial, so an non-inferiority rate of less than 3%, one-sided statistical significance. There were 3 interim futility analyses which showed the trial was on track and didn't require discontinuation, and the primary analysis was done after 500 disease-free survival events. And this is quite interesting actually, because it shows the way practice changed over that period of time from 2008 to 2015 when the trial completed recruitment in the UK. So on the top, you see that at the beginning, most people were receiving or giving sequential chemotherapy, whereas at the end, the majority were giving concurrent chemotherapy with trastuzumab. Also, the proportion of patients who were ER positive versus ER negative changed with time. This might be a bit of selection bias because you're selecting the patients who you think are lower risk to go into a de-escalation strategy. But the rates are not that different than affinity, in fact, because with time we've seen that 50% split between estrogen receptor negative and estrogen receptor positive, which was in all of the early Herceptin trials or trastuzumab trials, has changed to more of a what we'd expect for breast cancer as a whole. It's more like 2/3 to 1/3. That's the ratio in this trial. It's also the ratio in the affinity trial. And the change between giving more anthracyclines versus less. So I think, you know, as we'd expect with more concurrent treatment, giving chemotherapy with trastuzumab, you can't give an anthracycline with trastuzumab, so you give the taxane with trastuzumab. So we see a less exposure to anthracyclines, which is also probably a very good thing because that's one of the drugs that causes late effects. And in terms of disease-free survival, there's no difference. So it met its non-inferiority bounds, an absolute difference of 0.4%. The landmark analysis is very similar. The hazard ratio didn't cross the non-inferiority limit at its upper level, so it can be clearly said from this trial compared to the other non-duration trials that trastuzumab is given for 6 months is not inferior to given for 12 months. So some of the toxicities that we all see in practice is that, people say trastuzumab is well tolerated. Well, it is compared to chemotherapy, but does have some significant toxicities that all patients on treatment complain of. And certainly discussing these toxicities with patients, they are interested in some sort of de-escalation strategies. I think in terms of HER2-positive breast cancer, we're probably where we were when I did my training in terms of Hodgkin's disease, that we can think about strategies for de-escalation in some patients. Does the Persephone trial tell us which patients to de-escalate? Probably not. So within the NCRI breast group, we've been trying to develop a trial based on primary medical therapy with a combination of trastuzumab, pertuzumab and taxane chemotherapy, assessing response after 3 cycles for patients who are looking like they're going to progress to a pathological complete response, give them 1 more cycle, and then if they have achieved a pathological complete response, potentially randomize them to standard of care of trastuzumab treatment, whatever that might be, whether it be 12 months or 6 months, versus discontinuation with monitoring of circulating tumor DNA. But also important is what we do for patients that are not going to achieve a PCR. So that's on the left-hand side. Very preliminary ideas. This is by no means the design as it's going to move forward, but this is work in progress, is whether we randomize those patients to different treatments, and one consideration might be immune therapies, which are starting to come into breast cancer. So having talked about HER2-positive breast cancer, to change track and talk about triple-negative breast cancer. And in triple-negative breast cancer, also attainment of pathological complete response correlates with good outcomes. Event-free survival hazard ratio for those that have a PCR is 0.24, and the overall survival hazard ratio is 0.16. And certainly the interest in BRCA has come from this study led by Andy Tutt, that we know that BRCA-mutated cancers are deficient in homologous repair, and certain chemotherapy drugs, platinums, cause a high amount of damage that is normally repaired by homologous recombination. So a trial looking at carboplatin versus docetaxel, a very commonly used chemotherapy drug in the first line for patients with BRCA-mutated or triple-negative breast cancers. And this shows that giving a carboplatin to these patients improves the response rate, the objective response rate on the left-hand side for those that are germline BRCA-mutated, and compared to so for the population as a whole, there's no difference. For the BRCA-mutated population, the orange bar is the response rate for carboplatin. For docetaxel, this is the response rate. For patients without a germline BRCA mutation, there's no difference between the response rates. And that difference in response rate for the whole population, no difference again. But for patients with BRCA-mutated breast cancers, they have an improved progression-free survival if they receive carboplatin. And a lot of us use this as a rationale to add platinum agents to neoadjuvant treatment, and we were using rapid BRCA testing because the changes in who we were allowed to test came in at a similar time that we were able to test people who are younger, and we were starting treatment on a pathway where we would add in a platinum agent if they had a BRCA mutation, was certainly the way we started it in Manchester. But as time went by, a number of further trials were published that showed that the addition of platinum to triple-negative breast cancers generally improved pathological complete response rate. So this is an analysis of over 2,000 patients presented at ASCO this year, 9 trials that together show that the pathological complete response rate favours platinum, and this is irrespective of BRCA status. And the trials that looked at BRCA status, not all of these actually looked at BRCA status, also showed that platinum was favoured in BRCA-mutated breast cancers. So what else have we got for treating BRCA mutated breast cancers? Well, we have PARP inhibitors. So PARP inhibitors have been in development for many years. They've had a license in ovarian cancer for quite some time. Ovarian cancer is nearly always metastatic, for treating platinum-resistant ovarian cancer. But PARP 1 and 2 are involved in the cellular response to single-strand DNA breaks. Inhibition of PARP results in trapping of the protein on the DNA, and this also inhibits replication fork progression and increases the double-strand DNA breaks. And resolution of lesions caused by PARP is dependent on a functioning homologous recombination pathway, of which the BRCA1 and 2 proteins are important components, and therefore cells lacking BRCA1 and 2 are particularly sensitive to PARP inhibition, what's called synthetic lethality. So a trial looking at olaparib, which is AstraZeneca's PARP inhibitor, versus physician's choice of chemotherapy in patients who'd had up to 2 lines of chemotherapy previously in the metastatic setting. Randomized patients 2-to-1 ratio between olaparib and chemotherapy, and the olaparib came out better in terms of progression-free survival, and this has not yet led to a license, but is in the process of being a funded treatment. So how will we take that forward? Trials looking at the addition of PARP inhibitors such as olaparib with or without carboplatin in neoadjuvant treatment has been looked at. And this shows that the addition of platinum or olaparib does improve the pathological complete response rate compared to neither of those drugs added to the chemotherapy, but olaparib doesn't seem to add anything on top of carboplatin. So obviously this is good in terms of cost effectiveness, but may have some toxicity issues. But we do have an adjuvant trial which is currently recruiting. So for patients who've had chemotherapy, they can be randomized in the Olympia trial, which is looking at olaparib in the adjuvant setting. So randomization between olaparib and placebo for 12 months. Again, an arbitrary duration. And that's currently recruiting across the world. So just to change tack a little bit back to antibody therapies in terms of triple-negative breast cancer. So triple-negative breast cancers are particularly characterized by genomic instability, and this leads to neoantigens, which are potentially identified if you can unlock the immune system. We've seen over the recent years a raft of drugs that do unlock the immune system and allow the cancer to be seen by the immune system, firstly in melanoma, then in other cancers. So checkpoint inhibitors are the drugs that are being mainly looked at apart from in melanoma. So the T cell recognizes the tumor cell, but the interaction between programmed death ligand 1 and programmed death receptor damps down this pathway, inhibits the recognition. This is part of the normal immune protection system that stops your immune system attacking your own body all the time. But you can unlock that by giving either an anti-PD-1 or PD-L1 antibody, and various compounds are in investigation at the moment. One of which, atezolizumab, in combination with chemotherapy. If patients achieve a good response, a complete response, radiological response, so disappearance of radiological abnormalities, or a partial response, so that's shrinking the cancer significantly by measuring it on CT scans. Those patients that have a good response do very well long term. So this is a complete change from what we would normally expect in triple-negative metastatic breast cancer, where the median survival is typically 1 year. Which is what's achieved for patients who have stable disease. Those that have no response have a worse outcome, as you might expect, but patients that are having a good response seem to be having a good durable response. And atezolizumab in combination with nab-paclitaxel, there's no data because it's just a press release saying that the trial is positive and the data will be presented at ESMO. So very interesting to see those data when they're presented, but it's the first hint that immunotherapies are coming to breast cancer. So in conclusion, HER2-targeted therapies, particularly antibodies, have made a major difference in terms of treating HER2-positive breast cancer. We've now got to the point where I think we can think about de-escalation in some patients, but we still need new therapies that improve outcomes in others. BRCA mutation needs to be considered at an early time point when you're thinking about treatment strategies for breast cancer, but that might not necessarily include inclusion of a platinum agent in the treatment, because they're generally shown to be effective in triple-negative breast cancers, and certainly in terms of improving the pathological complete response. And we've incorporated those largely into our practice in South Manchester, for patients receiving neoadjuvant treatment, but also, if they're fit enough, receiving adjuvant treatment. So we standardly give a combination of a platinum with a taxane and continue with anthracycline and cyclophosphamide. So immunotherapies are also coming, and they will soon have an established place in the treatment of particularly metastatic breast cancer, but they're also being looked at in earlier breast cancer. Thank you for your time.